everybody, so we'll get started. You notice it's ischemia trials, plural, and we'll talk about that. There's actually more than one. I have no disclosures. So I'll start by reviewing the background and the landmark studies in stable ischemic heart disease that have been done in the contemporary era, and which establish really equipoise before the ischemia trials were done and justify the conducting of the ischemia trials. Then we'll get into the trials. We'll talk about the rationale and the design and the results. And then where do we go from here? And I should say that these trials actually have not been published yet. They were announced at the AHA, but the publications are not quite out. We expect them soon. So the first, and I think the most famous study in stable ischemic heart disease that preceded ischemia was the COURAGE trial. And recall that this was a randomized study of percutaneous coronary intervention plus optimal medical therapy versus optimal medical therapy alone. And this trial enrolled people after a coronary angiogram. And you see over here that they had to screen over 35,000 to find 3,000 eligible patients, excluded for various reasons, but about half of them were excluded because of things like recent revascularization, low ejection fraction, severe angina, left main coronary disease. But they ultimately were able to consent and randomize 2,287 patients. And what the study showed that in patients with stable ischemic heart disease, there was no survival advantage and there was no reduction in myocardial infarctions in the patients who were randomized to optimal medical therapy versus optimal medical therapy alone. A couple years later, Berry 2D was published, and this was a study of patients with type 2 diabetes who had proven coronary artery disease based on a coronary angiogram. And this study also randomized patients to revascularization versus optimal medical therapy alone. This study also excluded patients with left main coronary disease since there's not equipoise in that setting. And this study also failed to show a benefit of revascularization in stable ischemic heart disease when done in addition to optimal medical therapy. They did do this analysis where they analyzed patients by whether they were revascularized with percutaneous coronary intervention or CABG. And in the PCI stratum, there was no difference in survival or MACE, but I think it's important to point out that this trial was conducted in an era when drug-eluting stents were not quite standard of care. So there's a very high usage of bare metal stent use in the study. There was in the CABG stratum reduced major adverse cardiac events, but not a survival advantage. Then a couple years later, we had FAME2, which was a study that randomized patients with coronary stenosis and an FFR of less than 0.8. And these patients were randomized to percutaneous coronary intervention or optimal medical therapy. And this trial was stopped early because there was a significant reduction in their primary composite endpoint, which included death, non-fatal MI, or urgent revascularization. You see quite an impressive reduction. However, the endpoint reduction was driven almost entirely by this reduction in the need for urgent revascularization. There was no difference in survival or myocardial infarction. They did this interesting landmark analysis that you see over here in the figures, where they looked at events in the first 7 days, and they censored out patients who had an early event, and then they did a second analysis at 8 days and beyond. And you see in the first 7 days, there's a much higher incidence in the PCI group of adverse cardiac events. But if you could get through that window and not have an early event, there looked like a benefit to PCI beyond medical therapy. Now this trial, one of the criticisms with the trial that includes unstable angina or urgent revascularization is that this is not a spontaneous event. This is something that physicians assess and they order the test. So that introduces bias to a study. And the way to think about this is if a patient's randomized to the optimal medical therapy arm, but the treating provider knows that they have a coronary stenosis, it's FFR positive, if the patient subsequently has chest pain, you're more likely to attribute that chest pain to untreated coronary artery disease, and you're going to want to revascularize that patient. Conversely, if a patient who has been revascularized comes back with chest pain, you might be more likely to attribute their chest pain to non-cardiac chest pain. So you can see how you introduce bias when you use these softer endpoints in a clinical study. So when you look at the studies that have been done in the contemporary era that have looked at revascularization versus optimal medical therapy and stable ischemic heart disease, there's been 5 quality studies with an N of a little over 5,000, and 4,000 of these patients were proven to have ischemia with a stress test or FFR. And when you look at the forest plots here, there's no significant advantage for revascularization in death, non-fatal MI. There's an almost statistically significant reduction in the need for unplanned or urgent revascularization, and there's no difference in angina. So that's a summary of the clinical trials, the randomized trials that were done before ischemia. However, that's not the whole story. On the other side, you have observational data that might tell a different story. And the first large study that's well known came from Cedars-Sinai in their nuclear lab. And they looked at 10,000 patients and 10,000 consecutive patients in their nuclear lab who had a myocardial perfusion scan, and they looked at outcomes. And what they found was that if patients had 10% or more myocardial ischemia on their perfusion scan, there seemed to be a survival advantage if they were treated with revascularization. Now, I'll point out that in this 10,000 patients, only 671 patients were revascularized. And this was not a randomized study. They did do propensity scoring, but still, this is non-randomized data that suggests a survival advantage if somebody has moderate to severe ischemia. And if you look at the patients in the COURAGE trial who had perfusion scans before and after randomization, they showed that if you look at residual ischemia burden, so the ischemia left after they were randomized to revasc or optimal medical therapy, the more ischemia you had, the more residual ischemia you had, the worse you did. And they also showed that revascularization reduced ischemia to a greater degree versus medical therapy. However, if you look at the long-term follow-up of patients who were in the COURAGE trial, and you look at the 1,370 patients, remember the study had about 2,000 total, so about 1,300, they had data from, they had coronary angiography data and myocardial perfusion scan data, and they showed no difference. These are overlapping curves, whether there was mild or severe ischemia and whether they revascularized or on medical therapy. Only the number of diseased coronaries predicted survival, not the degree of ischemia. It didn't seem to matter whether the ischemia was mild, moderate, or severe. Ontario, they did an interesting study, a real-world study, where they looked at all the patients in Ontario who had coronary angiography, and this is about 40,000 patients total. And then they did propensity matching. They found 12,000 pairs of very similar patients who either were treated with revascularization or optimal medical therapy. And in this observational study, they did find a survival advantage and a reduction in myocardial infarctions that was statistically significant for patients who are revascularized. So I hope that I've shown you that before ischemia was conducted, there really was equipoise in this area. We have randomized clinical studies that showed no benefit for survival or reduction in myocardial infarction for patients with stable ischemic heart disease, but we also have observational data that suggests otherwise. So the hypothesis of the ischemia study was that an invasive approach of early cardiac catheterization with intent to revascularize immediately, in addition to optimal medical therapy, would be superior to optimal medical therapy alone in reducing the incidence of MACE for patients who have moderate or severe ischemia on a stress test. So this is the study design. You start with a stable patient with a stress test showing moderate to severe ischemia. The ischemia was originally determined by the site, but a core lab overread the stress studies to ensure that they really did seem to meet the threshold. The majority of patients would have a blinded CCTA if their GFR was greater than 60. If the GFR was between 30 and 60, and in the clinic, the clinician's judgment that left main coronary disease was unlikely, the patient could be enrolled without a CCTA. A core lab would then look at the CTA, and if the patient had left main coronary disease, they'd be excluded because there's not equipoise there. or if the CCTA failed to show obstructive coronary disease, then the patient would not be eligible. And then ultimately, patients were randomized to the invasive strategy, which called for optimal revascularization within 30 days, plus optimal medical therapy versus medical therapy alone. It's important to remember this is a strategy trial. Being randomized to the conservative optimal medical therapy arm doesn't exclude the use of revascularization later. Patients could be crossed over if they had unsatisfactory angina, or of course, if they had an acute coronary syndrome. So the primary endpoint in this study, and there was some controversy here, the original primary endpoint was time to cardiovascular death, or MI, but enrollment in the study was slower than anticipated, and the event rates were actually lower than expected. So they needed to expand the endpoint to maintain power with the clinical study. Now, it was pre-specified that they could expand the endpoint. This was a contingency plan that would be triggered by the Data Monitoring Safety Board. So ultimately, the primary endpoint ended up being the combination of cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or cardiac arrest. The other major secondary endpoint was quality of life studies done by John Spertus, who many in the room know well, really an expert in that area and who trained here. And then the components of the primary endpoint were analyzed as secondary endpoints. These are pretty standard eligibility criteria that you'll see in trials like this. Patients had to be over 21. The threshold for moderate or severe ischemia was 10% or more ischemic myocardium on a myocardial perfusion scan based on the sum difference score, or 3 or more wall motion abnormalities on a stress echo or a stress MRI. Some patients could be enrolled with an exercise treadmill test without imaging, and this was done because this is an international randomized study and not all countries utilize imaging as much as we do. So if a patient had an abnormal stress test with ST changes at 7 METs or below and accompanied by classic angina, then they were eligible for the study. Now, there were some enrollment challenges I mentioned. It was actually very hard to get patients into this study initially. And part of this was the intellectual versus visceral equipoise. David Marin used that term when he spoke to us about being here 4 or 5 years ago. And this was really, when I would talk to you guys, you'd tell me that, you know, you knew the data, you understood it intellectually, and it made sense to you that there was equipoise, but not for your patient. You had concerns. Your gut was telling you that your patient, severe ischemia or this very abnormal coronary angiogram, really needed coronary revascularization. And then, of course, patients are biased as well. Patients are not usually ambivalent about being randomized to a conservative treatment strategy versus an invasive strategy. And it makes sense to a layperson why having an open artery would be better than having a closed artery. So we had challenges there where we would identify patients and their referring doctor would be comfortable enrolling them, but the patient was reluctant to be randomized to these 2 different strategies. And part of this is the language we use. When we talk about fixing arteries in the cath lab, it implies that maybe revascularization can cure the underlying disease. We have to be careful with our language. But ultimately, we ended up at the University of Washington sites enrolling 13 patients total. We had 8 in the main trial, 4 in the I-CKD ancillary study, which I'll talk about, and then we had 1 patient in CHOW, which I'll briefly mention. This was just a paper some in the room might be comfortable with, but are familiar with, but this gets at why patients maybe were reluctant to be randomized. This was a survey of patients who were in the cath lab being referred for coronary angiography with possible revascularization. They surveyed about 150 patients, 10 interventional cardiologists, and the 17 referring cardiologists. Only 1/3 of the patients who were being referred for the angiogram had angina that they identified as limiting their quality of life. 77% had an abnormal stress test, and about 1/3 had a history of prior MI. But 88% of the patients believed that the PCI would prevent a future MI. Whereas 63% of the cardiologists felt that the benefit of PCI was only for symptom relief. And this study was done after COURAGE was published, and the results are very similar to studies that were done before COURAGE. So COURAGE really didn't move the needle in how patients and physicians think about coronary angiography. So worldwide, we ended up enrolling 8,518 patients. A little over 3,000 had a screen failure because of either the core lab deciding that there was not sufficient ischemia, or the CCTA showing no obstructive coronary disease, or finding unprotected left main in about 5% of the patients. I'm not going to talk about the study today because there's not results yet, but the CHOW study was for patients who had moderate to severe ischemia but were found to have non-obstructive coronary disease on their CCTA. They're being followed to see what their outcomes are. About 2/3 of these patients are women. So look for that in the future. Now, 5,179 patients were randomized, about 75% of which had the CCTA. Remember, about 25% had a GFR between 30 and 60, so did not have the CCTA. And 2,500 or so were randomized to each arm, and median follow-up was about 3 years. So if you look at the core lab, the qualifying stress test, about half the patients had severe ischemia on their stress test, a third had moderate, and a little over 10% did get in with mild or no ischemia. And this was actually because the way this trial was conducted is sites initially had to have all their stress studies overread by the core lab. But after proving to be competent at looking at stress tests, some patients could then be enrolled without core lab oversight. And some patients did get in without moderate to severe ischemia. The baseline characteristics are, of course, it's a randomized study, so they're very similar, with median age 64. About 25% of patients are women, 20% with a prior myocardial infarction. Remember, this is a study of stable ischemic heart disease without heart failure, so the median ejection fraction is normal. And patients had pretty good blood pressure and LDL cholesterol, and most patients, 90% in the main study, had angina, which is different than ischemia CKD, which I'll talk about later. And this is the breakdown of what the CCTA showed by number of vessels with greater than 50% stenosis. So about 20 to 25% had single vessel, about a third 2 vessel, and almost 50% of patients had 3 vessel coronary disease. And if you look at the involvement of specific arteries, the LAD was involved with almost everybody, and proximal LAD in about half. So this is legitimate coronary disease. This is not like the Orbita study with selecting a very low risk population in terms of coronary anatomy. This is risk factor management. This is baseline versus final visit in the study. This is not a comparison of the treatment arms, but at baseline, almost all patients were on statin therapy, but the intensity of statin therapy increased by the final visit, and there was good use of ACE and ARB. And this is risk factor attainment. If you look by LDL, systolic blood pressure, aspirin or antiplatelet use, not smoking, and whether they attained what was considered a high level of medical optimization. If you met all treatment targets in the trial, that was considered high medical optimization. So by the end of the trial, 40% of patients achieved that. And this is in line with other studies, such as Courage. So this is what happened and with catheterization and revascularization. In the invasive arm, the majority of patients received their coronary angiogram immediately, which they were supposed to. Over time, you see by the end of the study, almost 30% had crossed over and eventually received coronary angiography. If you look at revascularization, in the invasive arm, 80% of the patients ended up revascularized, and about 25% by the end of the study in the conservative arm were revascularized. This is just the reasons for crossover. Could be an ACS event, failure of medical therapy with uncontrolled angina, or unfortunately, some sites were just not adherent to the trial protocol and maybe crossed people over too easily. So the mode of revascularization, I showed you 80% of the patients were in the invasive arm were revascularized, about 20% were not. And it was 2/3 because of insignificant disease when they actually had their coronary angiogram, or a third who had such severe disease they weren't felt to be candidates for PCI or CABG. And of the patients revascularized, 3/4 received PCI, and a quarter received CABG, and there was high utilization of drug-eluting stents and arterial grafts. The site determined the revascularization strategy, and if PCI was selected, modern or fourth generation stents were used. And here's the outcome. So blue, this is conservative. This is the primary outcome, the combination of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And this is the invasive arm, where you have this early increase in events after randomization, but then the curves cross at about 2 years. So there's a non-significant reduction in the primary endpoint for the invasive group. But what you see here is at 6 months, there was about a 2% absolute increase. Or I'm sorry, at 6 months, there's about a 2% absolute increase in events in the invasive arm. But later, at 4 years, there's a 2% absolute risk reduction. So for the secondary outcome, it's a similar curve. This is just cardiovascular death or MI. There's this similar 2% absolute increased risk early with the evasive approach, but a 2% absolute risk reduction later. No difference in cardiovascular death or all-cause death. And they concluded, and again, they haven't published their statistics yet, that the probability of a 10% or greater risk reduction for death there's a less than 10% chance for that. So the study had adequate power to rule out that. Now the MI, I thought this was one of the most interesting findings in the study. So if you look at total MIs, there's more early in the invasive arm, but there's less late. And that's because if you look over here, there's of course more peri-procedural MI. You can't get a peri-procedural MI if you don't have a procedure. So there's more of that early, but there's a reduction in spontaneous MI. These curves separate early, and that's statistically significant. The hazard ratio is 0.67 with a significant p-value. So finding that revascularization reduces spontaneous MI, that's a new finding. Not all studies have shown that, and that actually goes against how we typically tell patients how stents work. Now, if you look at the primary endpoint and you look at all the different pre-specified subgroups, there's no heterogeneity of treatment effect for any group. So if you look at whether or not they had their stress test interpreted by the core lab, there's no difference. If you look at the degree of baseline ischemia, you might interpret this as a trend, but it does not mean significance. It doesn't matter even if you have severe ischemia, you did not benefit from early revascularization. Didn't matter how many coronary arteries were affected. And it didn't matter whether or not there was a high degree of optimal medical therapy. So those are the primary outcomes and the major secondary outcomes that I reviewed. Now for quality of life and angina was better in the invasive group. So at baseline, 20% of patients had daily or weekly angina, and almost half had angina several times per month, and about a third had no angina. And this is just the Seattle Angina Questionnaire score, and the change with treatment. Conservative is blue, and the pink color is invasive, and this is just density. So there's a shift, and there's of patients with improved angina if they were assigned the invasive approach. So quality of life was better. Now I'll transition to the CKD ancillary study. This was for, this came about because patients with chronic kidney disease are underrepresented in all of our previous stable ischemic heart disease trials. Berry 2D excluded patients with creatinine above 2, and Courage only enrolled 16 patients with a GFR less than 30. So we really have no data on these patients. And most in this room probably know that patients with chronic kidney disease, their highest risk of death is for cardiovascular reasons. So ischemia CKD was the same study design, but with 777 patients. And since they had severely reduced GFR, there was no coronary CTA performed. So the referring provider, in their judgment, they had to feel that left main coronary disease was unlikely. Similar baseline characteristics to the main trial, although only half the patients in CKD had angina at baseline. This has been shown in many other studies that patients with CKD are less likely to have typical angina. Ejection fraction was normal. For the patients who are on dialysis, the majority were on hemodialysis. And you see that for those patients not on dialysis, there's about 15% who had a GFR less than 15. Most of the patients in this study had stress imaging. Some had a treadmill, just like the other study. Since there was no CTA, we don't have coronary data on the conservative group. And you'll see that in the patients that assigned the invasive route, actually 25% with the abnormal stress test actually did not end up having flow-limiting coronary disease. And there was an equal distribution of arteries involved for the patients who did, and actually did find 2 patients with left main disease. So these curves are completely superimposable for the primary endpoint of death or MI. And same for the secondary endpoint, which includes unstable angina, heart failure, or resuscitated cardiac arrest. Now, when you look at the patients who were not yet on dialysis when they were randomized in CKD, there was a higher risk of death or new dialysis if you were randomized to the invasive arm. And the study protocol had very careful guidelines for minimal contrast use. In fact, the patient that we enrolled here, I think Creighton actually did the case, if I remember right, I think he used 0 contrast PCI for this patient. So it was a low contrast protocol, but even so, there was a higher risk of patients progressing to dialysis if they're randomized to the invasive group. So now I'm going to get into some of the limitations or questions about the study. And one is, was ischemia underpowered? This table comes from the original protocol manual that we were given, and they anticipated, this shows you if you look at the anticipated event rate in the conservative arm and the relative risk reduction that you would expect with the invasive strategy. And this table shows you what the power would be for these various circumstances. And they anticipated a 20% event rate in the conservative arm, and that there would, so if you look here, the power to detect a 15% relative risk reduction, had they done that, would have been 92%. The event rate ended up actually being lower, and enrollment also ended up being lower. So in the end, the study actually only has about a 65 to 70% power to detect a 15% relative risk reduction. So there's risk of type 2 error. Another thing that comes up is a peri-procedural MI, a real MI, and how do you define it? And there's been a lot of debate recently looking at the Excel trial that looked at left main coronary stenting versus bypass surgery. But in routine clinical practice, I don't think biomarkers are routinely checked post-PCI anymore. It's always done in studies, but where do you set the threshold? What's a clinically significant elevation in biomarkers after a PCI or a CABG? Some studies, but not all, do show increased mortality associated with peri-procedural MI. I will say that ischemia used the most stringent definition, which was a 10-fold elevation in CKMB or a 70-fold elevation in the troponin, or 50% of those thresholds with an EKG change or a wall motion abnormality on an imaging study, or if repeat coronary angiography showed a new occlusion. So the strengths of ischemia are that it's the largest study to date in patients with stable ischemic heart disease. It's about twice as large as COURAGE. This study proved that there is substantial ischemia burden at baseline, which is one of the criticisms of COURAGE, is that maybe not all those patients had substantial ischemia. The study was done with contemporary medical therapy, and there was pretty good attainment of optimal medical therapy within the study. There's very careful quality of life assessment and excellent retention of study participants. Now the limitations, enrollment was lower, events were lower, so the power may be inadequate. The endpoint was broadened to add these softer endpoints like unstable angina, urgent revascularization. We wonder, what would longer follow-up show? You saw those curves were diverging after about 2 years. So if we continued to follow these patients, what would we see? And we do hope that there will be some sort of extension study to keep following these patients. And then the study is not generalizable to everybody. You can't generalize this to patients with reduced ejection fraction, or patients with left main coronary disease, or patients with unstable angina. Now, did the media miss the mark here? We did not get a simultaneous publication from a medical journal, but we did get a simultaneous publication in the New York Times, which is our patients, many of our patients' medical journals. So this was the headline: "Surgery for blocked arteries is often unwarranted, research finds." To which this parody Bill Lombardi account replied, "Toilet paper also doesn't appear to save lives, perhaps unwarranted. Remind me not to share finger foods with the author of the New York Times article." Or a more measured response from Dr. Hira, who I'm sure many of our invasive cardiologists have encountered this in the cath lab since the study was published. Ravi encountered a patient who sounded quite sick with low EF, ventricular fibrillation, and refusing cabbage because he read this New York Times article. So I'll say we deal with this in clinic all the time with other studies as well. I know that this is very frustrating for interventional cardiologists, but we deal this with trying to get patients on statin therapy who read the People's Pharmacy, and this is our job as physicians, is to clarify the studies. It's good when our patients ask us questions, and it's our opportunity to answer these questions. Although I understand in the setting of an emergent coronary intervention, trying to explain to somebody the difference between an acute coronary syndrome and stable ischemic heart disease could be frustrating. Now, I've heard it said, one of the other criticisms of this trial is, why did we do this trial? We already knew this. Well, if that's the case, then why aren't we doing it? If you look in the NCDR registry, and you look at patients who are referred for elective cath, the rate of optimal medical therapy use before percutaneous coronary intervention is less than 50%, which is obviously suboptimal. And what's discouraging, no pun intended, but there was no improvement after the COURAGE study was published. These rates really did not change. So if we did already know this and the study wasn't necessary, then why aren't we practicing this? The other criticism I've heard is that for an NHLBI tax-funded study, $100 million is too expensive. But is a $100 million trial really that expensive when you think about the cost of the things that we're studying? This was a recent publication that looked at medical prices of several medical procedures and compared them to our, if you want to call it a benchmark, our benchmark. So if you look at the percent of the US price for all these medical procedures, we're the most expensive for everything except cataracts in New Zealand. I don't know what's going on there, but and the cost of a percutaneous coronary intervention is about $30,000. I got that number from this study, but there's other studies that I found that are similar, 25, 20 or so, and there's actually regional variation, but $20,000 to $30,000 for PCI. So if you have almost 1 million PCIs per year in the US, about 1/3 of which are for elective indications in stable ischemic heart disease, well, if you just do the math at 30,000 times 300,000 PCIs, that's almost $10 billion annually in expenditures on PCI. So in that context, I don't think a $100 million trial is expensive. So where do we go from here? I would argue that ischemia burden doesn't really matter. What we want to know is whether patients have coronary disease so that we can get them on optimal medical therapy. Because of that, I think a CCTA is probably a better first test. And Gary Huang just gave a great presentation a few weeks ago on this. But this isn't exactly what the ischemia study was intended to do, but we know that a CCTA can accurately identify the presence of coronary disease, even if it's not obstructive, and that can allow us to implement medical therapy. It can also find left main coronary disease where we know there's a survival advantage to revascularization. Because of this, the recent European Society guidelines now give CCTA a Class 1B recommendation, which is an equal recommendation to stress testing for a stable patient with chest pain. And the NICE guidelines from the UK actually recommend CCTA as the first-line test for somebody for a stable patient with chest pain. And I just wonder if the US will eventually follow. And of course, the big barrier right now is whether or not payers will reimburse us for this testing. So this would be my proposed approach to a stable patient with coronary disease and who has a preserved ejection fraction. I would recommend that we consider starting with the CCTA. If they don't have coronary disease at all, we don't need to treat them. We can think about other causes of chest pain. If we find left main disease, we start optimal medical therapy and refer them for revascularization immediately. If we find coronary disease without left main disease, we can start optimal medical therapy. That's safe, that's effective. And if it fails and our patients have ongoing angina or they become unstable, then they go for revascularization, right? And this really, we're not going to completely eliminate stress testing, but we can take it out of the equation for a lot of patients. And that's what I would propose we do. So take-home messages from these studies. I think the ischemia studies were worthwhile, if not perfect trials. Shows that OMT works and we can do better. We can increase our utilization of optimal medical therapy. Revascularization is still warranted and it's better angina relief. The study does not apply to patients with heart failure with reduced ejection fraction, recent ACS, or unacceptable angina. I want to see where the research goes and tells us about whether revascularization really does reduce spontaneous MI, because this goes against most teaching. And if it does, is it the actual stent or bypass surgery, or is it the fact that these patients are on DAPT? And then lastly, I just think that an anatomic study is a better first study for patients with stable symptoms and chest pain to evaluate for the presence of coronary disease and to rule out left. And lastly, I'd just like to thank everybody that was involved here. The clinical trials unit did a fantastic job. Fatima, Carly, and Bryn, who were the coordinators, they were amazing to work with. They did a lot of hard work, particularly to help with enrollment. And then Kelly for not firing me when we started slow with enrollment. My co-investigators, who were Eugene, and then Bilal Malik in nephrology was the CKD co-PI, and then our interventional PIs. And then I want to thank the referring cardiologists who had the courage to send their patients into this study. So Fareed, Hussan, and Zach. And lastly, the kidney transplant team was great. They allowed me to randomize patients who were on the kidney transplant list, and I really appreciated that. That's it.